This is Heart Rhythm TV, and I'm Daniel Alyesh. Welcome back to the ICE Image of the Month. I am joined today by Sebastián Giacoman. He is of the Hospital Universitario Clínico San Cecilio in Granada, Spain. Welcome.
Thank you for having me, Dan.
So our topic today is something that Sebastián is particularly skilled at, is ICE, and we all enjoy his posts, for zero fluoro cryoballoon ablation. It's a topic that people kind of hang on to the concept of using fluoro for cryoablation, and I think we'll be able to show various concepts, particularly with ICE, for how we can do this successfully. So as an overview, we'll start off with a couple references. We'll move on to transseptal and left-sided ICE. I think left-sided ICE is a critical concept for performing this successfully. Some concepts for verifying vein occlusion with ICE, particularly focusing on left-sided pulmonary vein examples. The approach to the left common pulmonary vein. How do we do esophageal monitoring without fluoro and with ICE and with particular catheters? And then troubleshooting that vexing right inferior pulmonary vein. So without further ado, we'll start with the references. A couple here. The first is a randomized study demonstrating in about 100 patients the ability to do fluoroless cryo using ICE to verify vein occlusion with Doppler and to show equivalent results in either arm, fluoro or non-fluoro. The second one is a bit of a shameless self-plug. It is in our paper where we talked about step-by-step how to perform a fluoroless cryoballoon ablation for AFib. Special thank yous to Brad Knight as well as Sri Sundaram for helping us put together this paper, and I think it's a very useful how-to guide. But we'll move on and we'll get to Sebastian's great images. So the first image, I believe, is, Sebastián, your approach to transseptal puncture and then bringing the ICE catheter to the left atrium to successfully perform the procedure. So I'll start the video and we'll have you talk a little bit about what you're doing here, what you're seeing, and all the concepts.
Yeah, we advance, at the beginning, we advance the ICE inside of the right atrium. And currently, we prefer to pass the ICE inside of the superior cava vein until at the level of the azygos vein, and advance the wire, advance the sheath, and advance the needle, and drag together the ICE and the sheath toward the fossa valis. Here we can see a very important point. Always we try to pass toward the left atrium in the center of the fossa valis, aligned to the left pulmonary veins. This is very important because when we want to pass the ICE toward the left atrium, it's very important to stay aligned to the superior, to the left superior pulmonary vein. It is safer and it is easier. When we do the technique ICE over the wire, we try to avoid always to have an important angle, a big angle, to posterior angle, or to put anterior angle, because it's more difficult to pass toward the left atrium when we want do the technique with the ICE inside of the left atrium.
I think this is a very, very great example. Thank you, Sebastián. I think it's important, when you're going transseptal, you have posterior tilt, right, to see your SVC as you drop. And then once you actually get into the left atrium, to buddy the ice catheter over the wire, and I think there's a great example here, anterior tilt. So you see you have your wire in view. Everything you're over in front of this portion of the ice catheter is anterior. You're going to go anterior tilt. So essentially, you're going to bring your wire right in front of you, and then you can buddy them over each other. It can go quite smoothly. And I think parking the wire in the left-sided veins, as you've said, is really important for doing this all safely. So a great example and really important for getting really clear views of the cryoballoon to have that ice catheter in the left atrium.
Yeah, one point. At the beginning, we put always the ice near to the ostium of the superior vena cava and near to the right atrial appendix.
Yes.
But discussing with Dr. Rasminia, the king,
Yes.
we agree that it's better and it's safer pass the ice inside of the superior vena cava, and after this, pass the wire, pass the sheet, and manipulate the ice and the sheet toward the fossa valis from the superior vena cava toward the fossa valis together. Because sometimes the ice could advance to the right atrial appendix, and this is not good. This point is very important.
No, I agree with you. I think the right atrial appendage can be very thin. And I like when you say, hey, we bring both these catheters down together, the ice and the sheath. And so I think very, very important point and critical for from the safety perspective. So let's move on to our next. So verifying vein occlusion with the cryoballoon. I think historically a lot of us have used contrast injections in fluoro, but there are data out there that you don't need to do that. And really ice is your tool. It's your vision for verifying occlusion. So here are two concepts, Sebastian, that you use for verifying vein occlusion. The first being Doppler. So I'll have you kind of describe the image that you have here and what you're showing us.
Of course, here we have the left suprapulmonary vein, and we put the catheter, and with clockwise rotation, we can see the left inferior pulmonary vein. And here we can see how we align the sheath and the balloon with the ostium of the left inferior pulmonary vein. Here we can see how the flow passes through the superior pulmonary vein. Here we evaluate the upper region of the left inferior pulmonary vein, and then you can see how we have a leak in the inferior posterior region of the left inferior pulmonary vein. This is very important because we can, with Doppler color, if we pass the ice inside of the left atrium, we can evaluate the occlusion with color with high accuracy. This is very important because in a high percentage of our patients, at least in European Spanish population, we don't have enough window to do the ice cryoablation only with ice. If you use the 3D electron-atomic mapping system, you can, but do it only with the ice from the right side, at least in our experience, is not enough, and it's more complicated in a high percentage of the patient evaluate the occlusion of the vein. I don't know.
I think it's very important. It's a very important point what you're saying. If you look at the ice image here, the front of your transducer, right? If you're in the right atrium, in front of here, you're typically going to see the septum. And I think thicker septa can really impact your view for looking at your left-sided structures. Now, these are equivalent images to your right atrial other than the septum is out of the way and the views are clearer. I think also because you're in the middle of the left atrium, you can visualize the right-sided pulmonary veins a little easier. But excellent points about the importance of left-sided ice. And I will let you, I really love this other technique that you do with the agitated saline for verifying vein occlusion. I'd love you to take us through what you're doing here.
Yeah, here we have a very interesting image because here we can demonstrate how we inject normal saline inside, in this case, inside of, inside the left suprapulmonary vein. We can evaluate the anatomy, the reach, and we can see how we occlude, a not usual technique, how we occlude the left common trunk. And we can see too how the normal saline cannot leave the vein, and secondary to this, we can see scars or a few bubbles inside of the left atrium. And this is a very nice example with a high quality image, how we can use the bubble technique to evaluate the occlusion. And always we use both the Doppler and bubble technique, because the bubble technique, it's a qualitative technique, functional technique that reflects in a 3D how it is occlusion. You can see in a 3D, this is the concept. With Doppler, you see only one region, you can see the leak. But with the bubble technique, you can see how is occlusion in whole ostium or in the whole antrum. That is a complementary technique that is very important to use when you want to occlude the vein and evaluate with high accuracy.
I agree. I think both of these techniques are very, very helpful. I'm going to acknowledge that I've learned something today. I haven't done the agitated saline technique before, but I think it really gives you a three-dimensional assessment of how well your occlusion is. And we've used agitated saline so many times in echocardiographic images. This is just a great application. So Doppler plus the agitated saline. I'll put in another plug for a technique that we use, which is pressure waveforms. Viewing, and we actually validated this in a case control study where we said we compared to, vein occlusion with contrast versus Doppler plus the change in waveform related to occlusion and found them to be equivalent. So adding this to our tool chest, adding the agitated saline, Sebastian, as well as the Doppler, and even if you want to do pressure waveforms, I think there are so many ways for us to avoid wearing lead and using fluoroscopy, and this is a great example. So the left common pulmonary vein, I think you've touched on this already, but it's one of those with the cryoballoon, how do you best approach it? And I think this is a beautiful example of how you use ice and how you approach left common pulmonary vein. So Sebastian, take us through what we're looking at here, please.
Yeah. Of course, in this case, we can see from the vision of the left atrial appendix, we rotate our ice catheter in a clockwise rotation to evaluate the anatomy in all patients before I start. And in this case, you can see a common ridge, prominent common ridge, the left common pulmonary vein, and we can see clearly the anatomy and the sheath on the left, and how we move the eyes to align to have a very good vision of the antrum to occlude the left common pulmonary vein. It's not infrequent when we try to occlude a real common trunk, because you have sometimes a common antrum, but you have two ostium, but the real common trunk, the real left common pulmonary vein, sometimes is quite challenging to occlude. And with the eyes, we can occlude the left common pulmonary vein and start with not occlusive ablation. And with Doppler, during the Doppler, we can optimize during the freezing. We can optimize the occlusion and have better biophysical parameters to isolate the veins.
Yeah, I think that that's a great example of how you can manipulate the cryoballoon after you've inflated, after you started freezing, right? Even with pull down techniques using Doppler to verify occlusion. So, thank you very much for that great summary. And I think we'll jump on.
Other point about the other point that is interesting about this slide, excuse me,
Oh, please.
it is, you can see how we can reevaluate the left atrial appendix before start the ablation. Here is quite near. You can rule out again the thrombus inside of the left atrial appendix. This is a very good advantage, because at the beginning you can rule out from the pulmonary artery. You can see the left atrial appendix, but you have other opportunity to reevaluate the thrombus inside. That is very important, because when we use the eyes, we have a lot of advantage, and we can improve the accuracy, and always the procedure, the intervention is safer. That is a very important point.
Yeah, I mean, I think that, dynamically being able to assess left atrial structures, assess formation of thrombus, even in the procedure on your sheaths, in the appendage. I mean, you should be using ice the entire procedure. I know that Dr. Razminia makes that point, and I think it really is a valid one. I mean, there's no guessing game, right? You're dynamically assessing these structures as the procedure goes on. So very important point. Now, esophageal monitoring, I think people really get hung up on it. They say, hey, I need to see my probe. I need to step on fluoro. Now, while this, I believe, is not a cryo example, I think this is a great example of how can we visualize the esophagus? How do we visualize our mapping catheters or specialized esophageal mapping catheters to be able to do this all safely and to do it with higher definition with ice. So I'll have you take us through this example as well.
Yeah, on this slide, we can see a video, and we can see how we introduce, in this case, the S-Circa catheter sensor inside the esophagus. And I think that this video is a very good video and a good opportunity to see how is the relation between the pulmonary veins and the esophagus. And it's very useful when we do RF, because it is a complementary technique. The eyes, it's a complementary technique to see the lesion and where we are doing the lesion and what is the relation of the lesion with the esophagus. In cryoablation, we can see how is the relation between almost always the left pulmonary veins with the esophagus. And in a high risk patient profiles, very low weight, older patient, very old patients, and women, we know that this patient, if we have quite near the esophagus to the posterior region of the left pulmonary vein, or the less frequent from the right pulmonary veins, we are more conservative with the biophysical parameters in these cases. And it is useful too with RF. With RF, we can see directly how we do the lesion and the distance with the esophagus. And in cryoablation is useful and it's a complementary technique. But you know, the lesions in the esophagus with cryoablation is less frequent, sorry.
Absolutely. I think that I guess there is an enhanced safety profile with cryoablation and the esophagus. But at the end of the day, fistulas, well, it's not zero. Fistulas are a much feared complication. So thank you for this example of how we can monitor the esophagus with ice, as well as integrating into the electroanatomic map and understanding how best to apply all this. So let's move on to right-sided pulmonary veins. I think there is a sense that it's very difficult to image the right-sided pulmonary veins effectively in cryoablations with ice. And I think no more difficult than the right inferior pulmonary vein. So I think this is a great example of how do we troubleshoot the right inferior pulmonary vein with ice guidance. I've always heard it referred to as the hockey stick approach. I think you must be more sophisticated in Spain because you refer to it as the golf club. But take us through these images and how do you troubleshoot the right inferior pulmonary vein with ice guidance here with cryoablation.
Yeah, and this is interesting. I love this video because we rotate the eyes toward the posterior wall. And then the first structure that we see always, it is the right inferior pulmonary vein when we rotate in a clockwise direction. And here we can see how we align, again, how we align the sheath, the catheter, and the balloon with the antrum of the pulmonary vein. At the beginning, it's quite challenging, but when you do your learning curve, we are realize that it's easier when we use X-ray. And we don't have used frequently the golf club or hockey technique because it's easier occlude the vein when you see with the eyes. And but sometimes, especially in patients, when you have the right inferior pulmonary vein quite near to the intra-atrial septum, or when the left atrium is quite small, in these cases, it's quite challenging to occlude the right inferior pulmonary vein. In these cases, we do the golf club or hockey stick technique. And the hockey stick technique, consists we stick the balloon against the superior region of the right inferior pulmonary vein. And again, other advantage of the ice, during the freezing, we can optimize the occlusion and see how we optimize the occlusion with the pull down technique and stick the balloon toward the inferior septal region of the right inferior pulmonary vein. And again, when you can see the structure, when you can see the anatomy, and when we understand the relation that we have, because sometimes it's very easy occlude the right inferior pulmonary vein because the right inferior pulmonary vein is more anterior, it's not too posterior. The problem is when it's too close to the interatrial septum, but sometimes it's quite near to the right superior pulmonary vein. And the occlusion of the right superior pulmonary vein is very easy. It's not difficult. It's very easy because you can align easier than you can align the sheath easier when you compare with the right inferior pulmonary vein. When the right inferior pulmonary vein is near and anterior, more anterior, and near to the right superior pulmonary vein, of course, it's very easy to occlude the right inferior pulmonary vein. The problem, and it is challenging when it's quite close to the interatrial septum. I repeat this concept because sometimes we have to drag the sheath and put only the balloon inside the right inferior pulmonary vein when it's quite near to the interatrial septum, or together when it's quite near, and when the left atrium is very small, quite small.
No, I think those are all excellent points for troubleshooting the right-sided pulmonary veins. I paused the image here just to demonstrate to the viewers, right? Left-sided ice. We're advanced into the left atrium. We have a very clear image of the right inferior pulmonary vein. You can see the ostium. And I think that that's an important point. When you're imaging the right inferior pulmonary vein from the right atrium, you often have the septum in the way, and you often you're going to cut off this rim of tissue here. You're not going to be able to see it as well. So I think great examples of really visualizing the right inferior pulmonary vein well, and then visualizing your sheath and exactly what you said, the concept of the golf club, kind of pinning the superior edge with your sheath and then pulling down over the course of the freezing to get the inferior rim. So, and then also talking about why it's difficult. Why is it difficult to treat the right inferior pulmonary vein? It's too close to the interatrial septum, getting the appropriate distance and angles on it. So, and I really appreciate your explanations. I always appreciate your ICE images that you post on Twitter or X. Really, really beautiful job. Sebastian, Roderick Tung always talks about global EP, how we're one big global EP community, and it's really wonderful to have you on the show. I think you've done a lot to advance ICE in the US and as well as in Europe and around the world. So it's always wonderful to see your images. You've made us all proud. You've made the Ice King proud, I'm sure too, as he watches this. So thank you for joining us on Heart Rhythm TV Ice Image of the Month, Sebastian. And thank you all for tuning in to Heart Rhythm TV.
Thank you very much, Dan, for inviting me, and see you soon. We will continue working in ICE together.
I appreciate the collaboration.